Hi, I'm Brian Rini from Vanderbilt-Ingram Cancer Center. I'm here at the GU Oncology Now ASCO roundtable with my friends and colleagues, and I'm going to let them introduce themselves. We're going to talk about frontline kidney cancer and then also talk about refractory kidney cancer incorporating the latest data. Tian?
Hi, everyone. I'm Tian Zhang, an associate professor at UT Southwestern Medical Center. I'm really glad to be here today.
I'm Pedro Barata. I'm also a GU oncologist at University Hospital Sideman Cancer Center, Case Western in Cleveland, Ohio. Also very happy to be here.
And I'm Michael Atkins, a medical oncologist and deputy director of the Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C., and I'm delighted to be here.
Thank you all for coming. I'm going to ask you all how the data at ASCO changed your opinion once I summarize it, but I think it's an interesting time in kidney cancer. Right? We kind of go back and forth, and IPI goes in and out of favor, and TKIs are great, and they're not so good, right? So I suppose that's what makes our job interesting. So let me summarize what we heard at ASCO about frontline, the frontline setting, and then I'm going to ask you each, how does that data, what do you think of the data, and is it going to impact your practice, and if so, how? So we heard two updates at ASCO. One was KEYNOTE-426, axi-pembro was a 5-year minimum follow-up, so it's the longest, it's the most mature data. We finally have that 5-year minimum follow-up for those patients, and then we had the CLEAR trial, len-pembro, which was 4-year minimum follow-up. So both reasonable follow-up, they're all 2 and 3 years behind ipi-nivo, just the way the trials played out. And what we've seen with IO-TKI regimens is really impressive early effects, right? A really good split of the curve, response rates, disease control, PFS of almost 2 years for len-pembro and CLEAR. And then what we've seen over time is those hazard ratios drift up, right? And they were in the 0.8 range, maybe it was 0.79 for CLEAR, I don't remember the numbers, but they're certainly drifting up over time. So you have, the way I take it, I'd be interested in your all opinion, is you have this early inflammatory driven group of patients that if they just get sunitinib, they're going to do poorly. And maybe it's sarcomatoid or whatever other biologic features we haven't yet defined. But if you take that group of patients out, if you will, right, if you treat them early or don't, well, then you're left with patients who are going to be able to get multiple treatments, right? And the data at ASCO, the sunitinib arm of 426, I mean, many of the patients got 2, 3, 4 treatments, right? So if you knew that on day one, well, this patient's going to be able to get multiple treatments, I think that would be different. You might approach that patient different. I don't think we really know that. I suppose volume of disease might give you some surrogate of that, but I don't think we know that. But I think we saw pretty consistent response rates, pretty consistent PFS. I don't think any of that number changed. And then the other question I think that I'd like to address is stopping therapy. So in all the IO-TKI studies, except for axitinib, IO was stopped at 2 years for just sort of the way the programs were designed. And so we have, I know in KEYNOTE-426, about 28% of patients who are completers, right, in that analysis. And not surprisingly, those patients are characterized by more favorable risk, lower disease burden, 85% response rate. I think the CRA was 16%, so patients have to do well to make it to 2 years. And then not surprisingly, I think it was 70% are alive at 5 years, and I think 30-some% are progression-free at 5 years. So, it really gets to the question of, should we be stopping IO? Is stopping IO sort of part of that drifting up hazard ratio? That's a question that I had when I saw these data. None of the trials have stopped TKI. I would much rather they continue IO and stop TKI, but it is what it is, but we can talk about that. So, I mean, to me, I think in part the data were reinforcing for everything that's good about an IO-TKI regimen, right? Response rate, PFS, disease control. I think they were a little more wobbly when it comes to durability, right? And that tail of the curve. And again, we're comparing across trials and all the normal caveats that we're all aware of, but that's what we do, right? When we're picking a treatment for a patient, we can only give them one regimen, right? And you can talk to the patient all you want, but at the end of the day, you're probably making the decision, right? Of what am I going to give this patient? So I think the data were interesting. I think it's super important to have these long-term data. So I give the companies credit for doing the analysis. I know for KEYNOTE-426, it's after the final analysis, right? The final analysis was the last one. That was the protocol specified, but we all realize these data are important.